Okay, I think we can start Dr. Sulaiman. Alright. Okay, Assalamualaikum and very good morning to everyone, especially to Prof. Madia, Dr. Sulaiman Murad, Dr. Ghazali, and to both our speakers, Mr. Vimal anak lelaki P. Rahman and also Encik Muhammad Hakim. Welcome to our collaborative teaching for OCT497, Occupational Therapy in Return to Work. So thank you so much from us to both Mr. Vimal and Encik Hakim for joining us today for the sharing sessions. So I hope both of you in a good state of health, and also I hope everything is going to be smooth today. Okay, so a little bit about our speaker today. Mr. Vimal is the head of Allied Health Professional at Integra Rehab Johor Bahru and have more than 10 years experience in clinical setting, while Encik Hakim is the senior occupational therapist at the Integra Rehab Johor Bahru. Is it correct? Yes, all right. So I think we can start. Okay, without further ado, I would like to invite Mr. Vimal to start the sharing sessions. Okay, Mr. Vimal.
Yeah, we will share our screen.
Okay.
Before that, I would like to thank the faculty members, I think Prof. Madia, Dr. Sulaiman, Dr. Ghazali, and also Puan Nurul for organizing this entire sharing sessions. And also the IHT Rehab as a private healthcare provider given opportunity. And we hope for the next 2 hours, all the students today able to get a bit of knowledge on what we are doing at IHT Rehab in terms of our return to work program. So when I think Puan Nurul first approached me, I was thinking maybe we should also talk about a bit more on the technical part. So that's why I call senior OT Akib to be also involved in that talk. My background is I'm a physiotherapist background, but as a head of the rehab unit and all that, OT is also one of the arm that I've also invested a lot of my time and energy, and also private healthcare settings is always a bit of unique challenge because investors, right? When you want to invest money in a particular, for example, OT unit in private healthcare setting, it's tough. So I had to do a lot of negotiations and all that. So okay, without further ado, we'll just start my talk today. We are sharing our screen. Want to check? Can you all see our slides?
Yes.
Okay, so our topic given today is our IHT Rehab Center Return to Work Rehabilitation Program. So before I start, I just want to touch a bit of on IHT Rehab. So who are we? And a little bit of history of IHT Rehab. So to start off with, this is our facility in Johor, IHT Rehab Johor. So this is just one part of how the facility looks like. Okay, so about us, IHT Rehab is it's considered the first fully MOH licensed private specialist ambulatory rehab center in Malaysia. So that means we are not a hospital. We are definitely not a hospital. We are under ambulatory care center license. So we are so-called a first rehab center using this license, ambulatory care center. So why we are unique than other centers, like other small centers or even private hospitals? Because the only difference I would say is we provide comprehensive and patient-centered multidisciplinary care. I think the key word that I want to highlight is a multidisciplinary care. So we are not just like a OT unit or a physio unit separate. We are all under the same roof. Under the supervision of a rehabilitation physician or a rehab doctor. So under that, we do have our rehab department or allied health department, which consists of physiotherapists, occupational therapists, and we do have speech therapists, psychology, dietitians. So all these 5 units work together under the supervision of the rehab physician. So our prime goal is to help individual recover physically, cognitively, psychologically, and also vocationally, which the OT part is very crucial. We want them to achieve the optimal level of functioning and also participation in society. So our flagship center in Iskandar Putri, Johor, we actually started Johor, I think, in 2022. And then from 2024 in 2025, we also have plans to expand to 5 centers. In fact, Selangor, we already started. Selangor, we started in December last year. KL, we already had a soft launch. We're going to officially launch in another 1 or 2 months. Penang's works are already going on, renovation works are already going on. Sarawak also renovation works already started. So only Sabah, we are still looking for a potential site for us to build up the rehab center there. So we are trying to match with international standards. So our investor is Integra Healthcare Technology, located in KL. Okay, so the general services that we provide, our ambulatory care center.
Mr. Vima, have you shared the
Also
the
Saturday and
slides?
public holidays. Sorry?
The slide is moving or not? The slide.
It's moving. Can you see the
Oh,
slide?
cannot.
Oh, cannot. Just give us a moment.
All right. Now it's moving.
Okay,
Yeah.
now moving. Okay. So
Right.
our ACC operates every day, 8:30 a.m. to 6 p.m. We are not a private hospital, so we only open during working hours, 8:30 to 6. And we do have like an accommodation building, ataupun we call it hostel, which actually provides 24 hours kind of accommodation services as a hospital. So what we have is accommodation. So it's just for patients or clients to stay. After the 8:30 to 6 p.m. kan, petang tu dia balik kepada hostel, they will just stay in the hostel. They can rest. We only have healthcare assistants to assist with the basic caregiving services. So we don't have nurses in the hostel, but we do have nurses in the ACCs to assist the doctors and do some services like wound, all that. Not a hospital, so we always have one ambulance standby 24 hours at our rehab center. So the type of cases sometimes we get is quite severe, like stroke patients and all that. On and off, we do have fitting episodes or seizures episodes during the rehab stay with us. So normally our doctors will try to manage it, and then they will send to the nearest hospital with the ambulance. And then, of course, we have cafeteria for the patients. We provide 4 meals per day. Okay, conditions we treat. Because we are a comprehensive multidisciplinary care, so we can actually treat many conditions. We can treat neuro rehabilitation, medical rehabilitation, musculoskeletal, or orthopedic rehabilitation. So you can see the list very extensive. Recently, we also are going to start for Johor, scoliosis rehab. Scoliosis rehab for teenagers or idiopathic scoliosis rehab. Okay, moving on. I would just want to touch on the clinical team. So these are our multidisciplinary team of rehab professionals. So as I've mentioned earlier, we have rehab doctors and rehab doctors assisted by 3 medical officers, and we have a team of nurses to assist the doctors. We have physiotherapists, we have occupational therapists, speech therapists, and we also have rehab assistants to assist the therapists, and we have healthcare assistants to assist in the hostel. One more unique thing we have is case managers. Case managers are macam pengurus case. This group of people actually assist patients from the day of admissions into our setup all the way until patient discharge. And they also work very closely with Perkeso local office case managers in terms of return to work, help us with coordinating work site assessments and all those things. So case managers is also a very important personnel for IHT Rehab. and we have dietitians, psychologists, and we also work with external prosthetists and orthotists with regards to doing a prosthetic leg or working very closely with a team of OTs for any modification or orthotic needed to ensure they are independent. Okay, so let me jump straight into OT unit itself. OT
Uh,
unit,
sorry,
can you
sorry
see
to
the slide?
cannot.
Oh,
Sorry.
okay. How about now?
Yes,
Or
yes,
maybe
now
we
can.
stop sharing. We stop sharing. We will share again. Uh, Mana? That is. I think there's some issues with the entire screen. I think entire screen better. Okay. Okay, so you missed the previous slides. Okay. Okay. Can you see the slide now?
Yes, can.
Okay. So these are the conditions we treat. Okay. So this is our clinical team, as I've mentioned earlier. And here we are. So OT. Can see the screen moving now? Hi, Panuru.
Yes, can, Mr. Vimal. Thank you
Okay,
so
can,
much.
right? Okay, can. So I just want to touch about the OT. I think the students here all know, right, the OTs and all that. But why we are a little bit different than the other OT units, especially in the private sector. Okay, we invested in a lot of technology, a lot of devices, so that we can actually provide a very comprehensive OT services for our clients or our patients. So we do run like conventional OT unit like other places. So on top of that, we invested in a lot of return to work kind of devices or facility. And then on top of that, we also do have other things. Maybe I'll just roughly go through with you all. Okay, as you all can see, we also started over here. We call it as a class or therapy sessions. We call it advanced upper limb training technologies lah. So we invested. If you can see the first video, the patient is working on Leucomate. Leucomate is a wearable sensor. We want to make OT sessions fun and engaging. So we the conventional session sometimes it's a little bit too boring for patient. So we invested in all these small technologies. It is very fun, engaging, and it also help patients to stay motivated with their exercise program. Instead of just counting 1, 2, 3, all those things, it is very fun. The the top or on the right, you can see the patient using dumbbell, a strengthening program, but we are using an interactive light system. So basically, it's a motion sense. When the light's on, the patient has to, move the arm. So it is also a very fun and engaging. On the top left, we can see is a robo hand, a spastic hand patients using it to do a bit of ranging, and also it helps to stretch the spastic wrists and fingers. So these are some of the technologies we want to promote upper limb motor recovery. So all this is very fun, engaging, and it also able to let the patients do multiple repetitions of exercises. I think the students you all know. Sometimes multiple repetitions, very specific movement actually accelerates neuroplasticity, especially in the neuro population. Okay, moving on, I would just want to touch another technology that we have invested for our OT unit here. The system is called EAS, or Eye Tracking Linkage Attention System, Digital Cognitive Training System. We are proud to say we are the first rehab center to implement this technology in Johor. So, what is unique about this system? Because it actually equipped with eye tracking system, which actually integrate visual and auditory stimulus to help improve the cognitive function, specifically targeting attention, concentration, memory, execution, and also visual perception. Okay, so when we actually tested this system with the vendor, we thought this system is very good because it has this unique eye tracking system. So kalau patients yang unable to express or unable to actually talk, sometimes OTs are having probably some difficulty in doing some conventional cognitive assessment or training. So this system actually with the eye tracking technology, it actually able for the OTs to use this system to actually gauge where is the cognitive function is like where is the cognitive punya status, a pre-intervention or a post-intervention. Over here, we actually use this system to do a pre-training, pre-cognitive training kind of assessment score, and then we also after they do a couple of weeks kind of digital training using this system for cognitive training, we also do a post assessment. So then we can know that whether the patient actually improve or not. Okay, moving on, the last part. Think, sorry, okay. So the next, we also invested in driving simulator. So I think the one in Johor is a bit basic, but if you have the chance to go to our IST KL, so we actually invested in the half cut. So separuh, the body of a car. So we put in this software inside the in the car together with all the dashboard and all that. So it is more realistic. For Johor, we only have this driving simulator, but we have plans maybe in the next couple of years. We also want to have a half cut body to be fixed into our software. So our OT here, they do a driving assessment and also driving off the road kind of training. So I'll just play one of our video, TikTok video. You can watch here where the patients, it's a stroke patients using the system. Okay, so I'll just move on to the next one. Okay, so moving on to the return to work, our topic today. So for IHD, we actually acquired two systems. The first system is a digital Archon functional capacity evaluation system. This system we just recently acquired. So it is from the US, and we also the only one in Malaysia acquired this system, Archon system. So we are still in the stage of testing out the system. We haven't fully utilized yet. In fact, in July, early July, we are calling the experts from US to actually, train our therapists to fully utilize the system. And we also invested in 15 WALPA component work sample unit, and we have 4 trained return to work therapists as of today. So this is our return to work setup in IHT Rehab. So I think that's all from my end for the introduction about the IHT Rehab and about the OT unit overall, and also the type of services that we provide. I will just pass over to Hakim, my senior occupational therapist, for him to continue with the IHT return to work program that we do in IHT Rehab.
Hello, good morning. Assalamualaikum. Is there anyone there? Am I still? Am I still?
Waalaikumsalam.
Salam. Okay, ada. Okay. Okay. So without further ado, sebelum tu, I would like to ask, can I like mix Malay and English? Is that fine?
It's okay.
It's okay. Okay, good. Thank you. So moving on. we'll be telling you a little bit about our RTW rehabilitation program development. So actually IHT started as per Sir Vimal said in 2022. So the RTW journey begins when we actually visited TTRC, Pakisuri Rehab Melaka Center, in September 2022. So this is basically our planning and testing phase. After a few months, VAPA work sample arrived, and again during this time we currently are using TTRC FCE method, which we actually learned from the visit on September 2022. After that, moving on in research phase, where we actually actively inviting lecturers, and we go to workshop and so on. Special thanks for Dr. Sulaiman and Dr. Ghazali for helping us in this phase, which is in March 2023, where Dr. Sulaiman and Dr. Ghazali actually trained us in using VAPA work sample, as well as return to drive rehabilitation, and how to report FCE, Joel FCE. So moving on May 2023, we actually sent two therapists to return to work workshop in HCTM UKM Ceras, and after that again a 3-day visit to TTRC Melaka on August 2023. Moving on to design implementation phase, which is during the period of research phase, we also had to design to digitalize what we have learned from Dr. Sulaiman and Dr. Ghazali's lecture, Joel FCE. And after that, on September 2023, we actually separate RTW unit from conventional OT therapies. Then for the current one, which is the follow-up phase, February 2025, which is the Arkan FCE arrived. Okay, this is our return to work flow chart. As you can see, there's a bit of colors here. So just to differentiate, the red color is more towards conventional part, whereas the orange color is more to return to work part. So we usually had a referral, then we do initial assessment and work conditioning as usual, where we focus more on the conventional part, which is the normal therapy of OT. Then after the patient is ready, then we will refer to RTW team, which then they will decide whether the patient needs to go to general RTW assessment or specific RTW assessment. After that, work hardening, and finally is functional capacity evaluation. Of course, it's either specific or general FCE. Okay, let's talk about FCE systems. So FCE systems, there's a wide variety of FCE systems which currently used and practiced commercially, international and even in national. So as you can see there, the list, internationally we have a lot of FCEs, a lot of FCE systems, but in Malaysia we can highlight there's 4 FCE that Malaysian are currently using, which is the first one, BTE Technologies, BTE Primus, BTE Eveltech, and very wide known Valpajo. Then a bit much more technological part is JTech, and currently the newest one is Arkan FCE, which were taken by us, IHT Rehab. Okay, as you all know, actually Joel FCE has been discontinued, so we are unable to actually invest on the Joel FCE hardware, but we actually came out with an idea to combine VAPA work sample components together so that we can actually perform Joel FCE. So basically the hardware is from VAPA work sample components, whereas Joel FCE system, we still use the manual training that were given to us. Okay, a bit on IHT Joel FCE documentation. So this is the final part. The one we actually shared with Dr. Sulaiman and Dr. Ghazali is the soft copy part, which is in words form. Then after a few months, we had the form digitalized, and here's the result. Okay, moving on for Arkan FCE system. So this is the new device that actually arrived on February 2025. Basically, Arkan FCE is a user-friendly tool to help clinicians do FCE in simple and accurate, consistent manner. In a way, FCE is very complete as somewhat the same as BTE technologies. But if you can say like BTE technologies, there's a lot of big hardwares. Whereas in Arkan FCE system, it's considered to be efficient due to a lot of small devices and also generated industry standard FCE that is approved by case manager and doctors. These are how the Arkan FCE systems looks like. Okay, moving on to pathway of IHT return to work rehabilitation program. Before that, is there any questions? Am I moving too fast? Laju sangat ke?
Many thumbs
Yes,
up.
boleh proceed.
Okay. It's very interesting.
Okay, semua okay
Okay.
Alright. Okay, saya continue. Okay. So a bit of overview in work rehabilitation. So basically, work rehabilitation is a broad term. In IHT rehab, we consider ourselves a return to work setting. Therefore, we have two types. We consider work conventional OT as work rehab as well, which is work conditioning, whereas the work hardening is the second part of work rehabilitation. So what is work conditioning and work hardening? Work conditioning is basically a systematic approach to restore the performance skills of workers recovering from long-term injury or illness. So we also focus on patients' functional, patients' upper limb functions, hand functions, sensory functions, cardiovascular, and we also focus on their ADL, IADL, and a bit of their cognitive as well. So typically, work conditioning is where we actually condition patients to be fit for work hardening phase. So for work hardening phase, it's a multidisciplinary approach. Of course, it involves employer, case managers, doctors, recommendation, and so on. It can also involve physical conditioning through, of course, simulated work activities, education, and also psychosocial interventions. Therefore, this work hardening also involves psychology to prepare patients mentally to return to work. Then, if necessary, with employers, final adaptation and reasonable accommodations can be determined during this period of transition. So, as per say work hardening, we do FCE, then we do FCE. Of course, we know the risk of patients return to work, their safety, and so on. Therefore, we will actually have employer conference at the final part of the work hardening phase. Okay, moving on. So, when the patient is referred to RTW team, we will do lump assessment of stage of employment readiness first to actually see patient's state of readiness to return to work. So basically, the interpretation is either pre-contemplation, contemplation, and action. So pre-contemplation is actually when the people in the stage of unaware or underaware of their problems regarding work, they usually have no intention to work in a foreseeable future. So it's either cognitively not aware, or they do not have the confidence to return to work, so they do not see themselves return to work in near future. So these are the people who are in pre-contemplation stage. Whereas in contemplation stage, they are aware that they have the problem, which is, of course, maybe financial problem, they have bills to pay and so on. So they have a thought to actually committed for a change, to then obviously this group of people will eventually change to action stage when we go through the RTW rehabilitation. So, and the last one is action stage. This is when the individuals actually involve, and sometimes in some cases they have search for suitable jobs that they want to go. They have already have an interest of what field that they want to work on and so on. And these are usually these are the patients that are very compliant with our return to work rehabilitation. Okay, I believe laser is actually well known in OT services, and even might be OT students as well. So we will actually, this is a self-rated question, but of course when the patient is have a language barrier, unable to read and so on, due to their education level, we will also conduct an interview. We ask them, explain them, and they try to answer, then we will actually mark for them. Okay. Okay, let's go to a bit difficult part of return to work rehabilitation, which is the work analysis assessment. So what is work analysis assessment? Work analysis assessment is a systematic evaluation of the job to identify physical, cognitive, social, and psychological requirements. So basically, it's used to identify the nature of work performed. So what is the purpose of WA, which is to understand patient job demands for treatment and intervention planning. So with WA, we can actually design intervention for the patients personally, and also WA is for work settings modification and risk management. We can also identify risks that the patient is going through, especially the one with heavy workload. And lastly is to personalize job placement and pre-employment screening. So based on WAA, we can actually decide whether patient, based on the current functional capacity, patient is likely or unlikely to return to their previous job. So in WA, of course, we assess the previous job pre-morbidly, the pre-morbid jobs. Then after that, after WA, actually we quickly know whether the patient is likely or unlikely. And through WAA as well, we can also prep the patients to be ready to actually find other jobs or other suitable jobs. Of course, the patient is well aware as well. Okay, so work analysis assessment. There are a few approaches to conduct WAA. The first one is, of course, interview. The second one, observation. Observation is also done during WSA. And sometimes we also email the company to actually send us the job demands of the patients, which is the job requirement for the patients to do at work, so that we can tally with our interviews. Other than that, we also we also look at the reference in the internet, which is through dictionary of occupational title. Okay, work analysis assessment. So there are 6 components of work analysis assessment, which is the first one is job title, job objective description, work and break schedule, work environment, work equipment, and essential job tasks. So these are the 6 components whereby in papers also states that these 6 components is needed in work analysis assessment. So I give you an example of WAA in the site, which is a job title is a lorry driver, job description, load, unload goods, driving and vehicle inspections, working hour 9 a.m. to 5 p.m., break time 1 p.m. to 2 p.m., then work environment, obviously lorry driver, outdoor and on road, and work equipment mostly lorry only. So the essential, as I listed below, essential jobs, lorry inspection, and the steps, the physical demands, and the frequency and the measurements, which is the frequency, duration, and intensity. Okay. Before we move on to functional capacity evaluation, is there any questions? Is there any questions so far? Okay, bagus lah. Semua thumbs up. Saya pun nak thumbs up jugalah. You with the slide? Okay, give me a thumbs up if everyone agree. Okay, ramai. Okay, kita continue. Okay, so basically, if you all, as you all know, OT is in charge with the functional capacity evaluation. So in many centers and even in Perkeso, OT is usually OT. In my view, OT is in charge with the product that is given. Product that is what we use for the what the employers want actually. So OT can give it to them, which is the functional capacity evaluation. So what is functional capacity evaluation? So functional capacity evaluation is an objective assessment for individuals to assess their work-related activity. So FCE compromise a lot of things, which is medical records, interview, muscle skeletal screening, evaluation for physical performance, formation of recommendations and report generation. We also, in our FCE, we also include cognitive functions and the functional part, which is ADL, IDL, where we can touch a bit on driving, patient's ability to go to work and go back from work and so on. So in the report also contains overall level of work, tolerance for the work over the course of a day, individual task cost, job match information, level of client participation, and intervention for consideration. Okay, so in FCE as well, as we can say, tolerance for work over the course of a day. So basically, FCE compiles everything. Let's say a 1 week work, everything in 1 day. So let's say the patients have lifting activity on Monday only, but not on the other days. We also need to consider that lifting activity is done in a day. As of course, the lifting activity is done in one of the particular days of the job. So we always take the worst case scenario. All right. So purpose of FCE. So FCE is to identify safe return to work abilities. Of course, every patients have their own impairments. So these impairments actually risk their safety in return to work, especially when the work is very harsh, very repetitive, and very heavy. So it's our job to actually identify whether the patient is safe to return to work or not. So other than that, to identify work abilities for job search. So let's say the patient is unemployed for a period of time. So he wants to return to work, but he doesn't know what work should he employ to. So from FCE, we can identify, we can also advise the patient to do a job search in this area or that area and so on. So other than that is to determine validity of injury of reported dysfunction. So for example, that the patients have an elbow fracture. So elbow fracture, usually the lifting functional capacity will be affected. Therefore, from FCE, we can actually validate the injury that is reported by the patients through one of the components of FCE. Other than that is to add information for determination of MMI. So MMI is actually a maximum medical improvement. Point 4 and 3 is actually kind of the same thing, which we validate what the patient is going through, and also we provide information for doctors to add up the information in their maximum medical improvement. So like macam the term jemaah doktor. So jemaah doktor will see this maximum medical improvement, and they have made it as a requirement for every patients to have FCE in their MMI. Of course, if the patient is very severe, then FCE is not that needed. So point 5, to add information in prep for settlements. So there are a few cases here where the patients had accidents, then which caused him knee level amputation, which then having to do lawsuits to the one who actually hit him. Therefore, it is required for him to do FCE to actually do some settlements from the lawsuits. Okay, next is to determine the need for other services. So in FCE as well, as I said earlier, return to work also involve multidisciplinary team, which also look into patients' mental conscious, whether they are suited for work or not, and which means for some cases that we need to refer it to psychologists, and also we can also refer it to counselor and so on. And through the FCE, we can actually try to refer it to other services. Okay, so for FCE, parties involved and roles and goals. So we have 6 parties based on the FCE that we've done here, which is the first one is physicians. The role of a physician is also is as a medical coordinator, which manage their medical and give us a clearance when we need to. So like for example, there's a few patients that sometimes their normal heart rate is actually quite high, which our normal heart rate is 120 to 80. Sometimes there's patients who have 150 to 130 consistently. So sometimes these kind of cases, to be safe, we refer back to physicians and get their medical clearance. If the doctors say it's actually normal for these patients, then we will proceed with the FCE. Next is the employers. Role is employment provider. So of course, the employers have their KPI as well. They will discuss with us on the patient's ability and how to actually synchronize with their KPIs. So sometimes we can also discuss with employers whether to place the patients in other positions and not their previous jobs. Other than that is case manager, which fills the roles of organizers. So case manager usually collects and evaluates clients' data to make a plan of action. So basically, other than physician, we can always refer back to case managers. So if like the patient's is job demands is really mismatched, so we can refer back to case manager for following plan, and the case managers can actually organize something for patients. So next is insurance companies, the gatekeeper. So insurance companies always related to private patients. Of course, their goal is to make sure the cost-effective disclosure as possible. Next, therapist as evaluator, the one who do FCE and so on, and clients, recipient of care. So clients giving feedbacks and also have questions that we can actually give them suggestion and so on. Okay, moving on to a bit more technical part of FCE. So far, is there any questions from the floor? Okay, so I'll continue. Okay, when we go to any we proceed with FCE formats. So basically, FCE formats there are four formats, which is I'm sorry. So currently we are focusing on FCE Joule only. So the FCE formats that I've given to you is based on the FCE Joule. So there's four formats, which is one day FCE, 2-day FCE, multi-day FCE, or targeted FCE. So we will go through one by one. So in one day FCE, of course, as the title said, one day FCE, it includes all the test protocols in the FCE, and it is bound with the sequencing rules, which I will explain later. So one day FCE, who is suitable for one day FCE? So one day FCE is appropriate for minimal to moderate symptom fluctuation with activity. So the patient doesn't have a lot of injuries, of course, no suspected manipulative behavior. Sometimes there's patient who actually manipulate us uh, with sometimes they act that like they couldn't carry some things and so on. So other than that, the patient's physical ability are anticipated to be near job demands, and lastly, their job demands doesn't require a lot of frequent continuous movement or frequent awkward positions. Okay, like for example, one day FCE, for example, that we can do in one session is like office workers. Like office workers, very minimal tasks. A lot of things are unaffected. No frequent awkward position and movement. So that kind of cases is suitable for one day FCE. Okay, moving on to 2-day FCE. So in 2-day FCE, for both days, we need to perform brief musculoskeletal evaluation. So in 2-day FCE as well, we can also retest problematic or questionable activities. So in compared to 1-day FCE, patients who have significant symptom of fluctuation with activity is suitable for 2-day FCE. Is basically an opposite for the 1-day FCE. Physical abilities are anticipated to be much less than the job demands. Job demands, there's a lot of awkward positions, a lot of frequent movements, and also patients who have suspected manipulative injury behavior, and patients who have cumulative trauma injury. Okay, moving on to multi-day FCE. So in a multi-day FCE is something that we do here in IHT. multi-day FCE and targeted FCE. The next one I will explain is something that we always do in IHT. Of course, if the patient can do all the protocols in one day, we'll do all the protocols in one day. And sometimes there's a bit unmatched demands, we will train them in work hardening and of course update the FCE along the way. So the appropriate patients for this multi-day FCE is basically primarily limiting factor is a tolerance. And sometimes when we do FCE, patients, when we do FCE, basically we are pushing the patients to the limit. So sometimes there's a few cases that objectively the pain score increased. When we ask the patients about their VS score, like the first day it's 2, then the next day sometimes it increased to 4 and 5. Therefore, multi-day FCE is suitable for this kind of patients. Okay, next is targeted FCE of also the format that we use in IHT. So based on WAA, we already have the job analysis which we found in the WA. Then we administer the FCE only for the targeted activity that is found in WA. Okay. Before we move on, can I ask a few questions to actually check if the floor actually understands what I present? Is that okay? Give me a thumbs up if you all are okay. 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 So the question is, from the slide, can you tell me how many FCE is used in Malaysia? If nak buka suara pun boleh, nak type pun okey juga. Okay, 4 FCE, very good. Okay, well done. So again, from the slide as well. Yeah, I pun kena go through with it. Okay. Can you tell me the overview of return to work rehabilitation, which is there's 2 part. What is it? Okay, very good, Balkish, very good. Okay, the next one, very recent. How many formats and what is the format of Joule FCE? How many formats? One question. Okay. How many formats and what is the format? You can type or you can open your microphone and tell me. Okay, very good. Okay, thank you for your participation. Okay, I'll be continuing with the slides. Things will get a bit more complicated, but bear with me. Okay, if you have any questions, just raise up and ask the questions, okay? And you can always write the questions in the chat box if you want. Okay, moving on to protocol configuration. So there are 5 protocol configuration, which is rare, occasional, no identified limitations, frequent, and constant. So the example here in the description shows the 8 hours shift. So some patients do 12 hours shifts as well. So you can always calculate it. through the percentage they are given in the table. So like rare is 5% of the working day. In other words, less than 25 minutes per 8-hour shift. Occasional, 6 to 33% of the working day, which is from around 25 to up to 2.5 hours. No identified limitations is more than 33% of the workday, which is 2.5 hours and above. Whereas frequent, 33 to 66% of the workday, 2.5 to 5.5 hours in 8 hours working shift. Then lastly, constant, which is more than 66% of the workday, which is 5.5 hours per 8 hours shift. Okay, I'll give you a minute to actually read this. And of course, I have some questions later. A while lah, tak adalah seminit lama sangat. Boleh Okay, senang je, rare 5% ataupun rare less than 35 minutes, occasional up to 2.5 hours, frequent 2.5 to 5.5, constant more than 5.5 lah. Okay, semua 5 je. Okay, but this is for 8 hours punya shift. If 12 hours punya shift, then dia ada perubahan sikit lah. There's a change there. Okay, so we move on. So these are some components that we will discuss further on. We can categorize these components, this activity, this protocol into two, which is something that we tested once or something that we tested 2 or 3 times. So in the description letter, you will understand what does this means, because for some protocol, some position, it's unideal to actually do straight 10 minutes or straight 20 minutes. So FCE, Joel FCE actually put it into sets. So like for example, kneeling, 6 minutes of kneeling is one set. Then the patients, based on the WAA, what we found, the frequency of the patients is frequent, which is based on Joel, it needs to be tested twice. So kneeling, 2 set is, you can say it represents 2.5 to 5.5 hours of kneeling per day. Something like that. Okay, I'll explain more later. Okay. So tested once, as stated here, lifting, unilateral carry, bilateral carry, push-pull, grip, walk, sit, stand, and balance. Whereas tested 2 or 3 times, fine motor coordination, kneeling, crouching, repetitive squats, stair climbing, repetitive foot motion, sustained elevated reach, certain mid-level reach, and crawling. So if you look at the activity pun, you macam, of course it needs to be set. Can you imagine repetitive squats for 10 minutes straight, 30 minutes straight? Confirm patient penat ni. Okay, moving on for FCE, of course in any modalities there's contraindication. So this contraindication is that we highlighted a few things, which is the first one is high blood pressure. So high blood pressure, as I give you an example before, if the patients have high blood pressure, any contraindication here, we always need to refer back to physicians to have a medical clearance. Maybe the patients need to be seen by doctor first, then the doctor said, doctor give us a green light, then eventually we do the FCE. Next, uncontrolled medical conditions or pregnancy, of course, no FCE. Unstable or acute stage of injury or illness, indications of intoxication or excessive use of medications. So macam lakluk lah, macam fly itu, contraindication, don't do FCE. No pay source, this one is for private patients, no insurance and so on, of course no FCE, no money, no top. So under age of 18 or over 65. So under age of 18, I believe not working age, and over 65 also not working age. Then assistive device if normally worn at work. So basically, this assistive device, it is one of the contraindication. Let's say patients have PID, which is sakit belakang lah, sakit belakang. The assistive device that were used waktu kerja dia guna, which is dia guna the yang pinggang tu, lambar korset tu. Dan waktu FCE dia tak guna. So waktu kita nak buat FCE dia tak guna. So make sure kalau patient use the assistive device during at work, it also need to be worn during FCE. Because it will affect patient punya result. So kalau ada banyak macam lain sikit tu macam susah sikit lah. Can be a manipulative behavior juga. So next is medication prior to testing. So if patients take medication at work, patient also need to take medication during FCE. So basically to make it more valid and constant at work and during FCE. Okay, next, safe testing endpoint. So in Valpajo, sangat-sangat terkenal dengan their safety measures. They make sure that the patients is in good condition, baru boleh buat FCE. Ataupun they make sure that the patient's performance are safe, baru patient tu layak dapat apa yang dia buat tu lah. Which means kalau make sure if the patient is lifting 20 kg without any body mechanism failing, lost balance and so on, then the patient deserves that 20 kg written in their report. So if dia angkat 20 kg, dia nak angkat 20 kg, tapi kita nampak okay, body mechanism not good, sometimes lost balance, badan sengit je, okay, they don't deserve the 20 kg lah. So safe testing endpoint ada 4. So the first one is successful completion of the test protocol. So in WAA, for example, walking, occasional walking. Then we test FCE, occasional walking, dapat. So complete. So safe testing endpoint, successful completion. Okay, next is client refusal. For example, patient sakit belakang. Okay, sakit belakang, kita nak buat mid leverage, sustain mid leverage, maknanya patient needs to do activity while bending forward, with their a bit lower position like a mechanic to do some activity, but patient refuse. Can be due to a lot of reasons, pain and so on. Okay. Next is client reaches maximum ceiling of safe level of cardiovascular exertion. Okay, this safe testing endpoint is specifically for patients with cardiovascular issue. Of course, we always calculate patients lower limit and upper limit. It can be not 0.7 or 0.8. It can be 0.4 to 0.6, which is very risky. 0.6 to 0.7 can as well. It depends on the patient's level, patient's cardiovascular ability given by their cardiologist. So the next one is client reaches a mechanical maximum ceiling of safe performance. Like for example, significant recruitment of accessory muscle group. So you lifting waist to waist level. Waist to waist level sometimes for strong patients only use biceps only. But for some cases, if they have reached the limit of the weight, they sometimes use body straps. They sometimes bend their waist a bit during lifting. So when that happens, you need to stop the FCE. Okay. Next is significant deviation from neutral position, as I explained before, the ability to maintain primary position. Before this, badan tegak je, next dah badan sengit-sengit dan sebagainya. Okay, decrease control. Like for example, during angkat berat tu dia tak ada jerking. Dia tak ada jerking. Can be loss of balance as well, decrease control. Waktu dia angkat tiba-tiba ada jerking, then we consider patients already reaches their limit. Okay, significant change in ambulation, of course, lost balance. Okay, next. Okay, as I said before, in 1-day FCE, there's a sequencing rules. Okay, these are the sequencing rules. It's very important. When you do 1-day FCE, sequencing rules ni need to take kata dari hati lah. You need to make sure. So the first one is paperwork and health history questionnaire must be performed prior to musculoskeletal examination. So anything history, job history, WA, everything of that kena ambil before musculoskeletal examination. Next, musculoskeletal examination must be performed prior to any functional testing. So, for example, musculoskeletal examination is MMT. So, MMT for both lower limb and upper limb function, upper limb MMT, we take it first before we do any functional testing. Okay, except they put an exemption here, except grip strength, hand coordination, or repetitive foot motion, which is something that they can do without the musculoskeletal examination lah. In other words, it is safe to do without musculoskeletal examination. Okay, next, perform sitting and standing before repetitive foot, or perform repetitive foot towards the end of sitting or standing test on day 1. So basically, this advice, these sequencing rules, is actually is a tips for us to save time or to arrange the activity neatly. So during the sitting or during standing, you can do repetitive foot. You can take two components at the same time. You can test sitting. While you test sitting, you do repetitive foot motion, and while you test sitting, you can do grip strength and so on. Okay, next. Fourth, core lift must be performed prior to carry and push pull. Okay, logic lah. So if you want to do carry, you do core lift first. Of course, you nak angkat barang daripada waist level, is a core lift. Carry, you do core lift first, then you do carry. Okay. Macam kita nak bawa barang tu, kita angkat dulu. Sebab tu kita test angkat dulu, baru kita test bawa barang. Okay. So, of course, push-pull sekali sama. Number 5, standard lift, carry, push-pull must be performed prior to custom resistive test. Okay. So, of course, FCE is very flexible. You can do custom resistive test. But make sure you do the standard FCE first before you do custom resistive test. Contoh, okay, like FCE, very standard. Guna equipment, bakul and so on, very standard. Whereas guna equipment bakul tu is lagi simple daripada angkat beras 20 kilo. Contoh standard lift guna bakul tu 20 kilo lagi senang daripada angkat berat, angkat bag 20 kilo. Yeah, something like that. So macam patients punya job demand is angkat beras. So angkat beras is another thing, standard lift is another thing. So make sure you do the standard lift first before you do custom resistive test. Okay, which is the angkat beras tu lah, custom. Where we notice that the patient have a bit different style, so we do that. Tapi make sure you do the standard one first. Okay, next, balance test must be performed prior to ladder climbing on day 1. So again, logic, you do balance test before you do ladder work. So kalau tak lagi, kalau you tak check dia punya balance dulu, because the balance test can menentukan whether the patient is able to do ladder climbing or not. Okay, next, 7, alternate upper extremity and lower extremity test and test of cardiovascularization. Okay, dia ada bagi example kat situ, walking, squatting, stair climbing, or in other words, I lagi suka we do upper extremity, we do grip strength, then lower extremity, we do squatting, and the next one, we do stair climbing, which is cardiovascularization. This is to actually maintain patient endurance, during 1 day FCE. Okay. Of course, they put a disclaimer as well, unless the job requirements dictate otherwise. So unless the patient's cardiovascular exertion during work memang banyak, so we need to focus on that first, and so on. Okay. Alright. So moving on to FCE protocol task according to Joe. Okay. Let's have a break first. Sambil-sambil rehat ni, saya nak tanya soalan sikit. Okay. Can you tell me the 5 configuration protocol yang I explained before? The configuration protocol. Ada 5. Boleh sebutkan kelima-limanya. Seorang satu pun boleh lah kot. Kalau seorang nak bagi 5 terus pun boleh. Boleh dengar ke? Okay, satu rare, very good. Ada satu rare. Thank you Raida. Frequent, okay, thank you Nick. Lagi? Occasional. Occasional, occasional 2. Betul. Lagi 2. Constant, very good, constant. Another one? Last kali. No identified limitations. Okay, very good. Okay, semua betul. Okay, next questions. How many sequencing rules yang dia explain tadi? Ada berapa banyak sequencing rules? Okay, 7. Very good. Okay. Next. Okay, let me check. Okay. How many safe testing endpoint yang saya explain tadi? Safe testing endpoint. Bila boleh berhenti? You buat FCE bila boleh berhenti? Ada berapa banyak? Macam I explain panjang tapi ada few je. Very good. Okay, 4. Okay, thank you Nick, Balkis and Harsha. Okay, next we continue with the protocol. Okay, so very simple. FCE protocols ada 4 protocols. The first one is forceful task. Second is positional tolerance task, repetitive tolerance task, and lastly upper extremity protocol. Okay. Before we start with the forceful ataupun weighted task, just keep in mind this thing. So we usually categorize the patients into 3, which is level 1, level 2, and level 3. So level 1, apa kriteria-kriterianya? Okay, this thing is actually the recommend you if the level 1 the progression should be how much, if level 2 the progression is how much. Okay, start dengan apa, end dengan apa. Okay lah. So for some patients you can actually skip lah. So takkan every patient nak start with 0 kg. Sometimes good patients you boleh start a little bit more advanced, macam the state above lah. Okay, I'll explain more. Okay, so what's the criteria that we can actually categorize this patient into groups? So level 1 is the history. The work history is sedentary to light work. For example, kerja office. Office work, sedentary. So level 1, maybe dia ada lifting, angkat dokumen dan sebagainya. So when we categorize the patient into level 1, we start with 1.1 kg. Then we progress half kg. We progress until dapatlah berat documentation yang dia angkat tu. Okay. Okay, other than that is when we do muscle testing, the MT score at least 3 per 5, at least 3 lah. Okay, of course dia ada bagi tahu expectation juga. So let's say in level 1, it is anticipated lifting capacity at waist level less than 9 kg. So make sure when you progress, make sure you dah moving towards 9 kg, you dah slow down, you dah start focus, you start being careful, because we don't want to risk patient punya safety lah. Okay, next, level 2. Level 2, history of work, medium work. Okay, maybe lorry driver, kena angkat barang, so medium work. Muscle testing is 4/5, considered level 2. So the anticipation, lifting capacity 9 to 22.7 kg at waist level. Okay, so when the patient reached 9 kg to 9 kg, you need to be careful already. You need to stay focused, look at the patient body mechanism and so on as the patient progress. Again, start with 2.3 kg and progress with 1.1 kg weight. Okay. Next, level 3, 4.5 kg as starting point, 2.3 kg weight progression. Okay. History, heavy or very heavy work, MMT 5.5 and anticipated greater than 22.7, you need to be careful already. So in my experience, ada patient, this one patient badan tak sadar pun, biasa je, tapi angkat 40 kilo waist level. So during 22.7 kg, I dah careful. Okay, this patient may fail. Okay, and then patient boleh angkat sampai 40 kilo, baru ada fail in body mechanism, dia dah start jerking, dia dah start balance, ada balance issue, then I stop the FCE. Okay, alright. So forceful task, in Joel FCE ada 6 tests, whereas in IHT we test up to 10 forceful tasks. Like in Joel FCE, the core lifts, 3 core lifts, which is 1, 2, 3. Then you have unilateral carry. Unilateral carry, obviously there's 2, 1, 2, 5, which means right and left. Okay. Then bilateral carry 6, push, pull 8, and in IHT we do pushing and pulling. 1 more, 2 more, pushing and pulling. So total of 10 forceful tasks. So what's the difference between push-pull and pushing and pulling? So basically push-pull is a static movement, static test. Like for example, grip strength, static, you test like that. Whereas pushing and pulling is a functional, dynamic test. Pushing trolley, pulling trolley, that is the difference between push-pull and pushing and pulling. Okay? Okay, try to remember this one. Okay, weighted forceful task. The first one is waist to waist. Next is waist to floor. This one is very simple. As I explained before, if level 1 start from 1.1, progress 0.6. If level 2, patient is level 2, then start with 2.3, progress with 1.1. Then if level 3 start with 4.5, you can progress with 2.3. Okay? Okay, waist to waist level, waist to floor level, that is waist to above shoulder level. Okay, it can be above shoulder or it can be above waist as well. It's considered above shoulder juga. Okay, shoulder level lah, shoulder level. Okay, shoulder level we consider above shoulder punya component. Alright. Okay, moving on. Bilateral carry and unilateral carry. So basically, In Joel FCE, it requires for the patient to walk 50 feet. 50 feet. Practically 50 feet tu jauh lah. So we do 25 feet and come back. 25 feet, you turn, come back. So bilateral carry, bawa 25 kaki, patah balik pun 25 kaki. Sama juga unilateral carry, kanan, bawa, patah balik. Kiri pula, bawa, patah balik. Then we progress, slowly naik, 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 naik. Okay? Okay, moving on. Push-pull. Push-pull, here we use this cable. So we can test maximum up to 20 kg. Up to 20 kg for both upper limb. Okay? Okay. So this is a bit of how to actually report FCE. I'm going to touch a bit on this lah. Tapi sebenarnya kita nak touch on report tu banyak. So we touch more or less touch sikit-sikit pun okay lah. So macam tadi, we have protocol configuration. Okay, that is one frequency. That frequency more focused on time. So this other frequency is more focused on the weight task. Okay, so basically, when we do WA, we will ask the patient, how heavy do you lift? Okay, you need to identify how heavy is the object that the patients need to lift. Then we also need to identify that lifting activity, berapa lama angkat barang. So usually in FCE, we will put job demand, let's say occasional or frequent 10 kg. Frequent 10 kg means in 8 hours shift, patient tu kena angkat 10 kg cumulatively total 5 jam. Boleh bayang tak? 5 jam angkat 10 kg. Kiri kanan ke atas bawah ke, kena angkat 10 kg. So from here we know at least the patient need to have the ability of how much. So kalau frequent 10 kg, then patient ni kena angkat berapa berat. Lebih kurang macam tu. Faham tak? Okay, contoh. Okay, this one is a bit complicated. If you have the software, if you put the last safe weight lifted pun, dia akan list out the occasional, frequent and constant. But since the system is no longer available to purchase, so this is something that we learn, and sometimes we of course we need to learn lah, untuk understand what it takes for the patient to do this kind of activity. Okay, I give you one example. Okay, if the patient reported in WAA lifting up to 20 kg. So dia kena angkat barang, contoh dia angkat bateri, berat dia 20 kilo. Okay, itu satu. So berapa lama dia kena angkat 20 kilo tu? Dia kata lebih kurang 1 jam dalam sehari. 1 jam dalam sehari tu dah kira occasional, which is more than 25 minutes. 25 minutes to 2 hours is considered occasional. So occasionally memang kena angkat 20 kilo. So we need to train patient up to paling sedap pun 40 kilo. If the patient FCE reaches 40 kg, then the job demand is made. Faham ke? Faham ke? Pening? Anything faham ke? Ke nak saya explain lagi sekali? Kalau explain lagi sekali, saya give me a thumbs up. I'll explain some more. Okay, explain sekali. Okay, So basically, based on this one, okay, based on weighted task, okay, ada dua configuration frequency. Okay, I explain one more time. If tak, I continue lah. Okay, sebab ada time restraint. Okay, so this protocol configuration, okay, nampak kita ada timing. Description is timing. Okay, you can see here timing. So you kena take consider in Joule FC ada dua configuration, protocol configuration. The first one is this one, more focus on timing. Okay. Then you have the second one, which is weighted task frequency. This one focus on how much the patient can live. Okay, 2 point number 1. One is timing, one is how much the patient can live. Okay, so when you do WAA, okay, I tulis kat sini lah When you do WAA, you found out patient waist to waist lifting is 20 kg occasional. Okay, 20 kg occasional. Ni realitinya inilah dia punya tugas walaupun berat. Okay, 20 kg occasional. In other words, 1 hour per 8-hour shift. Okay, patient do 20 kg cumulatively 1 hour. Tak adalah berterusan 1 hour, tapi dia buat 10 minit angkat 20 kilo. Lepas tu tiba-tiba lepas selang 40 minit, 10 minit lagi angkat 20 kilo. Tambah semua 1 jam. 1 jam kerja yang dia buat tu, angkat waist to waist lifting. Okay, 20 kg. So my question is just now, FCE expected berapa yang dia kena angkat supaya dia fit untuk dapat occasional 20 kg? Ataupun soalan dia, how much is the safest, how much ability is the safest, how much is the safest weight yang patient kena angkat so that patient job demand met 20 kg occasional. Okay, so the answer is 40 kg because in the weight task configuration, occasional is 50 to 100. So safest maximum need to be 40 kg so that occasional tu falls paling rendah dalam occasional. Dia falls under yang paling rendah dalam frequency occasional, which is 50 kg. Okay, of course, if the patient can live up to 30 kg, is considered made demand juga. Okay, made demand because we have a range 50 to 100. So, but we always be safe and train patient up to 40 kg so that the occasional that the patient have less issue doing occasional lifting. Okay. Okay, is there any questions? Okay, I'll proceed. Okay, I'll proceed. Next slide. So, in this slide, there's a rare, occasional, frequent, constant, no identified limitation. No identified limitation tu tak ada. So, for rare, last safe weight lifted, then you go down 50 to 100 for occasional, frequent 30 to 50, and constant 15 to 30. Okay, from the safest maximum lift. Alright. Okay, next is positional tolerance task. So, positional tolerance task ada 6. And during the positional tolerance task, you can also do some fine motor activities, any resistive activities, or any non-weighted activity during the positional tolerance task, as long as it doesn't affect the balance during the positional tolerance task. Okay, so these are one of the example. If I said, as I said before, there are some components that need to be tested twice or thrice, and some components need to be tested once. So these are examples that need to be tested 3 times, which is kneeling, sustained mid-level, and sustained elevated level. Okay. Okay. This one, patient need to assume position as in the picture up to 6 minutes 3 times in 1 day FCE to get a constant result. So the frequency, if the patient succeeded do 6 minutes 3 times in 1 day FCE, then the patient layak untuk dapat constant. So the ability he or she can do constant kneeling. Okay, let's say jatuh bawah sikit. Okay, 2 times, 6 minutes 2 times. Then patient akan jatuh. Patient can do frequent kneeling activity. Jatuh lagi 1 time. Patient can do occasional kneeling activity. Jatuh lagi bawah 6 minit. Patient can do rare kneeling activity. Jatuh bawah lagi, unable to do. Then unable to do terus. Okay? Ingat 6 minutes 3 times. Okay? Next, crouching pun sama. Cuma timing dia agak berbeza, which is 2 minutes. Like the last 3 is 6 minutes. For crouching 2 minutes. 3 times as well. And for sit and stand, up to 45 minutes. So if the patient can sustain 30 to 45 minutes of sitting, then the patient is entitled to constant sitting activity, constant standing activity. Okay? Next, repetitive tolerance protocol. So repetitive tolerance protocol, there's 7 tolerance protocols in Joule. The first one is walking. So walking, of course, you can use treadmill, or you can also just walk freely in a safe area. For your information, our normal walking speed is 3.2 km per hour. So you can always put a description in FCE. Okay, patient can walk 20 minutes, but how fast? What is the pace of the walking? Need to be stated in the FCE as well. Okay, same thing in stair climbing. So stair climbing, you need to test it 3 times. Okay, 3 minutes per set. Okay. Same explanation. If patient can do 3 minute stair climbing 3 times, then constant. 2 set only, then frequent. 1 set only, then occasional. Less than 1 set, then falls under rare. And lastly, unable. Okay, next, balance. So for balance, Joel have a different set of instruction, which is the patient needs to walk forward and backward. Okay, forward and backward. So basically in balance test, we need to provide patient with 8 foot long, 4 inches wide beam. So a little bit higher, 4 inches wide beam. Lebar dia 4 inches. Okay, patient walk. So basically macam it's a simulation of workers in construction site. So dia letak papan, dia jalan atas papan tu. Okay, so the patient need to do 4 times. Walk forward 1, walk backwards 2, walk forward with load, walk forward with load 3, walk backward with load 4. Okay, if the patient can do all of those 4, then consent. If the patient have some error and so on, based on the Joe, there's a bit affected that can go to frequent, can go to occasional and so on. Next, ladder work. Ladder work, patient needs to repeat 5 times in 1 set. So basically there's 3 sets. If patient can go up, do some work, come down, consider 1. Can go up again, do some work, come down, until 5 times is considered 1 set. Then you need to do 3 sets. Okay, next, Same thing, repetitive squat. Repetitive squat, patient need to do 2 minutes of continuous repetitive squat for 3 sets. Okay, if patient can do 3 constant, can do 2 set, then frequent can do 1 set, then occasional, less than 1 set, then rare. Cannot do, then cannot do. Okay, same thing for repetitive foot motion. Okay, again 2 minutes bilateral leg if possible, like for stroke patients can use one leg, then use one leg only. So the timing is in 3-second interval, one depression and naik. Okay, 1 2 3 tekan naik, 1 2 3 again tekan naik in 2 minutes, of course 3 set. Okay, lastly is kneeling. Yeah, kneeling, crawling. So basically, patient need to crawl up to 25 feet and rise. If the patient can do this 3 times, then the patient is considered constant crawling activity. Then lower. Okay. Okay. Lastly is upper extremity protocol. Okay, upper extremity protocol. There are 2 upper extremity protocol based on Joe. The first one is grip strength, and the second one is fine motor coordination protocol. Okay, very simple. I think you guys know as well. The first one is grip strength protocol. You can use JAMA grip strength on, and the next one is Purdue backboard. We here use Purdue backboard. As Purdue backboard has their normative value, we can always refer to that. Okay. Okay, I'll be touching a bit on post-return to work rehabilitation. So, post-return to work rehabilitation, there's a few you can do, which is referral for any treatment in need. So, after RTW, maybe the patient has some, the patient's physical functional capacity is good, but patient have visual impairment, then need to refer to another profession like ophthalmologist doctor, optometrist. Okay, patient physical is good, but psychological is not that good. So refer to counselor, psychiatric, refer to psychologist and so on. Next, post RTW rehabilitation. One of the most frequent done here is employer conference. Okay. This employer conference is to discuss patient's current ability. If match, then there's not much issue. If there's a mismatch, so if there's a mismatch, we need to discuss with the employer if there are any other position to offer to the patients. Maybe a little bit light work. Of course, we recommend that we can put some recommendations, light work ability for a time of period and so on. We put recommendations, always need to have a partner during job and so on. This will be discussed in the employee conference. Okay. Next is job trial placement. So, like I said before, we do WA at site visit. We can always do WSA again during the job trial placement. So upon like 2 weeks of job trial, we can come to the patient's work setting and follow up with the patient's conditions, whether the patients can adapt well, whether patients can have any issue and so on. Okay. All right. That is all. Okay, is there any questions from the floor?
Thank you so much, Mr. Vimal and Cik Hakim. Okay, kita nak beberapa soalan daripada our students. Do you have any questions? It's very interesting slides and very detailed regarding FCE. Thank you so much.
Thank you. We are glad to share. I think we also have to thank in the initial phase of startup. I think Prof. Dr. Sulaiman and Dr. Ghazali actually assisted us.
Yes.
I mean, I think it's about the more we do, the more we get better. I think the team here with Hakim and the rest of the other return to work therapists, the more they talk to employers, sometimes bagi input. Like sometimes employer question us, betul ke macam ni? Then we know, oh actually, then we should probably, you know, move because sometimes belajar dekat sekolah dengan real world, sometimes there's a little bit of mismatch.
Yeah.
I mean, because the real world sometimes is different. So when we do more, I think now the team is more capable. They have talked to many type of employers. We also managed to convince some employers. I think that's the good part of return to work team and all that to change to light worker. Sometimes kita letak liability also they want to know what liability, how long, duration and all those things. But of course there are also some limitation like I think like commercial driver. Kadang-kadang banyak ni like we do have some commercial lorry driver nak bawa container balik boleh. So certain things we know we can't do, we will tell difficult. Because that one is so sometimes we step up them, we send back to Perkeso Melaka because we are like a panel center. So certain capability we know that we can't do, we will admit, we will tell to Perkeso, okay, case ni maybe you all ambil. Certain things, the one we can help, definitely we will try to help. Okay? Yeah.
Okay, any questions?
Ada questions?
Kalau tak pasal RTW, pasal IHT Rehab pun boleh.
Yeah. The place is very interesting. May I know, other than Perkeso Melaka, where you get the referral to get the patients?
Okay. Currently, when we actually started 2022, we were 100% Perkeso patients lah. Perkeso patients, those are staying in the hostel, and also we open as an outpatient for Perkeso. Those who are staying around Johor area lah. Yang JB area biasanya dia datang sebagai outpatient. But the very severe one, like stroke, spinal cord injury and all that, definitely they stay in the hostel even though they are orang JB. But then apart from there, I think since last year, 2023, towards the end of 2023 onwards, we also started taking some private patients. So private patient, those who pay out of pocket, macam duit sendiri, bayar for therapy. We also have a lot of panel, what we call third party administrator. Kalau pernah dengar pasal MyCare, PMCare, some of the companies, they do have group insurance for their workers. So they do send us their patients for rehab. And then it's covered by their company punya insurance lah. So that one also we started to have a lot now in Johor area lah, maybe JB area. And then on top of that, some of the personal insurance yang bayar untuk medical card and all that, bergantung pada policy apa yang diorang ambil. So some policy apparently boleh, but dia kena pay dulu. Dia kena dahulukan money dulu, they pay for our services, and then they will try to claim later. So far we have also successful for some like Prudential, Zurich, AIA, pernah, bergantung pada apa policy yang ada, diorang ada. And then we also started to market for our international clients. So we do get quite a number of Singapore patients coming here because Johor very close. And then some from Batam. Johor naik ferry je 2 jam boleh sampai. So we have some Batam patients. And some expats, those like working kat Johor, ada Korean, ada from Chinese national, and some British nationals lah. I mean, these are limited lah. So we also started to serve some international clients for Johor. For Selangor, belum lagi because the team is baru December, baru 6 bulan. So I think slowly, maybe towards the end of this year, they will also start to serve some private clients lah.
Okay, correct. Okay. Dia malu-malu ni. Do you have any other questions?
I have question.
Okay, right.
Okay. For my question, for Cik Hakim and also Mr. Bima. So, as you conclude the presentation of both of you, so as we student, also we get to know early about return to work. Just kita baru berkenalan. So what should we focus on now to prepare for working in return to work rehab setting, especially in private sector, and also from both of you own perspective. So that is my question.
Okay, maybe I will touch a bit from the management perspective. I think return to work in private setting, not many places offer. I know that the one quite successful, I think Prince Court, they do have a bit of return to work. I mean, university hospitals definitely ada, but apart from there, maybe some selected like KPJ or they may have selected. But then it will be probably a bit of smaller scale because also depends on doctor punya referral. So this will be the challenge lah. Probably you will still need to see your conventional, OT, and then kalau ada cases, maybe you have to do, or you just bring your own patients, together from conventional dah habis, then you bawa kepada return to work, you yang buat something like that. But maybe for like Pekeso Rehab itself in Malacca, I think they're going to open another one in Ipoh very soon, maybe end of this year. And for us, IHT Rehab panel, we are different because we do have the volume. I think, for example, Hakim's punya team, one therapist, sometimes they have up to 10 patients only for return to work. So that's the difference because you will only see patients coming for return to work only. So it's very specialized. That's what we actually wanted also because kalau you buat conventional, you buat ni, you're being stretched. So we don't want that. So that's why we created like a team of return to work therapists dedicated to provide only return to work services. On a daily basis. So then they will only, the more you see, the more you come up with your FCE. Your FCE reports gets very accurate. Employers no question asked because when we started first also, many questions, employer ask ini kenapa macam ni, and we have to, sometimes we find, actually we could have write it a bit better. We learn from mistakes, but the team is now more capable. Lesser inquiries coming from employer once the FCE go to Pekeso and Pekeso sending to employers. So I would say, for students, definitely get your, university. I think UITM, you are in the best hands for return to work. Trainers are there. And then after that, real world is what you want in a private hospital setting kind of or something like Pekeso Rehab or even IHT Rehab where we have a dedicated team for return to work. Maybe I'll pass to Hakim to answer the technical part of it.
Okay, my perspective, what do you need to be in an RTW setting? First and foremost, apply there. Apply somewhere that have a RTW setting. As a student, I expect you to do conventional therapy first. But in the setting, we will train you to be an RTW therapist. Of course, we send you workshop there, workshop here. But in a way, have a conventional OT skills first. You come and you learn. Of course, the first step is you need to apply in the RTW setting. Okay, next. I feel if you talk about skill based, I believe you need to be a good multitasker. That's number one, multitasker. Second, you need to care more. You need to care more. Is of course as an OT, you care about patients, ADL, and so on. But in return to work, it's much more dangerous than doing ADL. So you need to think a bit more careful for the patients. Next, the third one, I feel that you need to have a good negotiating skills because when it comes to RTW, you need to convince the employer. Okay, contoh employee tu sakit. Dia tahu, the employer tahu, employee ni sakit. So how you need to convince the employer to take back this employee. Padahal the employer tahu sakit teruk juga ni. Macam mana you nak convince the employer to take back the employee. I think these three is most important. Other than that, very simple stuff lah. Macam willing to learn and so on. Okay. Alright.
Okay.
Thank you.
Thank you for the question. Very interesting.
I think, do you have other questions, or we can close here because we already near to 10:30. Dr. Sulaiman and Dr. Ghazali, any things to say to Mr. Vimal and also Cik Muhammad Hakim?
Thank you, Banurul. Assalamualaikum. Very good morning to all. Thank
Waalaikumsalam, Dr. Ghaz.
Hello. Okay.
Hello. Yeah,
How are you, both of you? Everything's good,
Good,
eh?
good. Yeah, good.
But I know I'm really enjoying your sharing session, and this is a part of the refreshing for myself as well. Eh? Even though for the lecturers, we also need to get some contact and input. Lama-lama pun berkarat juga. So I think both of you, your sharing session is really well.
Okay. Thanks,
Students as
Doctor.
well.
Thanks, Doctor.
Thank you.
It starts from you, Doctor. Kita belajar pada you juga dulu.
Thank you very much.
Alhamdulillah, at least bring benefit to all of us.
Okay.
Thank you very much, Mr. Vimal and also Mr. Hakim.
Sure.
Very comprehensive overview of work rehab. I am very proud, especially to Hakim. Hakim well presented just now. Really in depth what you're doing there. You know, whatever we taught in the theory in our class, at the end, the application is very, very important. So Hakim have set a benchmark for our student here. The way he presented the knowledge of that, the skill. So this is the benchmark that you all that are going to be graduated soon. So so when you want to practice return to work, this is the benchmark that you must have. Another thing is that the talk that you give, Mr. Hakim, very, very comprehensive. We try as much as we can in the theoretical class and lab. However, very important is that they practicing it. And our student here is your future client, future OT. They're going to work there. And you all, IHT have grown so fast, and you have a lot of cawangan already,
Yeah.
So you are the one that they're going to be work for in future, and I hope that our student here have interest and motivation to work at what they have. Thank you very much, Mr. Vimal. And
Okay.
Mr. Hakim, thank you very much. Okay.
Our pleasure. Thanks for inviting us.
Okay, before we end our session, can we take a picture first? Okay, students can open your camera. Change that. Okay. We wait for the students. Okay, Balkish, Zarif, okay. Okay, right. Okay, 1, 2, 3. Okay. One more time. Okay, one more time. Okay, 1, 2, 3. All right. Okay. Thank you so much, Mr. Vimal and Cik Muhammad Hakim. Any last word from both of you?
Just all the best to the students. As what Dr. Sulaiman say, we are expanding. So if those are interested in return to work or as a OT, we are very comprehensive. So you can apply once you have graduated. So we already have many of your alumni here, UiTM alumni. So we will be you all are more than welcome to apply to us if you are interested in this adult rehabilitation and return to work.
We expect great things from UiTM graduates.
Wow, okay, listen.
Banyak testimoni, Cik.
Okay. Okay, thank you so much. Last one. Thank you so much for Mr. Hakim. Memang sangat comprehensive the slides. Other than that, before that tadi Mr. Vima ada share about ada specialist from the US nak datang untuk give training. Don't forget to make a course lah for us to come. Mana tahu kan boleh datang juga kan. Okay, alright. Okay, I think that's all for today. Thank you so much ya. Okay.
Thank you.
Okay, Assalamualaikum. Alright. For the student, please isi your future for your attendance ya. Alright.
Thank you, Madam.
Thank you, Madam.
Alright, thank you for today.
Thank you, Madam.
Thank you, Madam.
Madam.